Hi, everyone, and welcome to another episode of Wellness Day, a podcast coming to you every Wednesday here from the Jahangir Wellness Center. My name is Kavas Jahangir, and here from the JWC studio, I've got Dr. Godbole. He's got a wealth of experience in diabetes for over 40 years. Diabetes is a topic that we've covered quite extensively here at Wellness Day. Today, however, we're going to focus a little bit more on what everybody is talking about, especially in India. That is GLP-1 drugs, Ozempic, Mounjaro, and we've got the expert here himself, Dr. Godbole. Thank you so much for being here, Doc.
Thanks for having me, Akawas.
Thank you. As I said, right now we're in the craze of everyone talking about GLP drugs, Ozempic, this, Mounjaro, that, weight loss, this.
Yes.
Ozempic face and so forth. So let's try and break down some of the noise and myth and help people through understand what this is. Is it good? Is it bad? Is there a wonder drug available? How is it going to help people? So I thought that would be a good, topic that we talk about. So perhaps we can start about, in your years of experience in diabetes. One is that how do you think that treatment has changed of diabetes since you first started?
So when I started, practicing diabetes 40 years back, things seemed simple. We only thought of diabetes as being a end result of one or two pathophysiological defects in the body,
Right.
and therefore there were only a couple of drugs we could juggle around with. And then slowly we realized that diabetes is a pretty complex disease.
Yeah.
It's rather a constellation of diseases. And there are so many, upwards of 8 to 10 pathophysiologic defects that make up diabetes. So initially when I started practice, our whole focus was merely lowering the blood glucose levels, no matter how.
Okay.
And then subsequently the emphasis shifted to safety. How do we lower blood glucose levels without causing unduly low blood glucose?
Okay.
And how can we achieve normal blood glucose without causing weight gain? And then, in 2008, there was a mandate by the US FDA stating that any new anti-diabetic drug that you bring to the market must be proven to be safe for the heart.
Of course.
And then came a series of trials, and then that completely shifted our focus from merely glucose lowering to using drugs which also, for example, reduce illness due to cardiovascular causes, heart attacks,
Right,
strokes,
right.
due to kidney diseases. And then now, as you mentioned, with the use of these GLP-1 receptor agonists, Ozempic, tirzepatide,
Right.
which also target weight. And weight is a proximal event in the pathophysiology of diabetes. It's obesity that very often comes first, and diabetes follows. So now we have drugs which actually strikes at the root cause of diabetes.
Exactly, which
And
is
also
weight.
other chronic diseases,
Right.
not just diabetes,
Right.
but a whole lot of chronic diseases. Which is why now the focus has shifted to drugs which not only lower blood glucose levels, but also lower the unhealthy fat in the body, which is actually the cause of diabetes in many cases.
So you're saying that's actually a good
It's a good
progress
thing,
and good
absolutely.
development.
We are
Because as you said,
addressing the root cause of diabetes, yeah.
which is weight in most cases.
Yes.
Right. What is a GLP drug
So GLP
or GLP?
So GLP stands for glucagon-like peptide.
Right.
Okay. So it's a protein. A peptide means a protein. And when you swallow glucose, through the mouth, the insulin is secreted from the pancreas immediately. Rather than if you were to take the same amount of glucose and inject it through the vein, if you take it orally, the response of insulin is better. It's magnified. And that is because as soon as glucose is swallowed, certain cells in the gut get stimulated and start producing hormones which are called incretin hormones, one of which is GLP-1. So GLP-1 is a hormone naturally secreted by the body,
Okay, yeah.
but it has a very short half-life. It easily gets eliminated from the body.
Okay.
So the challenge is to prolong the action of GLP-1, because that would on the one hand stimulate insulin, but on the other hand it also acts on receptors in the brain to suppress your appetite, to cause early satiety,
Right.
to improve your preferences from fatty foods to more complex carbohydrate food, so healthy food.
Yeah.
So food preferences change. It will also act on the gut. It will slow the gastric emptying. So these are truly wonder drugs because they act at various organ levels.
Interesting. So actually, GLP is not like some foreign
No, it's not a foreign
chemical
thing.
that
No,
you're
no.
injecting yourself with. It's actually you're just enhancing what's sort of already in your body.
Yeah, we are enhancing the action of GLP-1, which is native to the human body.
Okay. Interesting.
So you increase the levels of GLP-1 like 5 or 6 times
Right, right.
compared to what normally occur in the body. So you get a magnified effect, which is why you get all these benefits.
Yeah. And I mean, how long has this been around for these drugs? Because it's
So-
like something that only people are starting to talk about more and more now. But I believe it's been
So
around
as
for
a
a long
class
time.
of drugs, more than 10 years now, you previously had drugs like liraglutide,
Right.
which was a daily injection. And
Okay.
now we have shifted to either an oral formulation,
Right.
which is truly, I would say, a Nobel Prize winning discovery.
Yeah, yeah.
To make a protein into a pill is unprecedented. Otherwise, the protein gets digested in the gut.
Right.
Now you have a pill which has a protein inside.
Yeah.
So that's a Nobel Prize.
And it's so much more accessible for people
more
to take.
accessible to people. And you also have once a week injections, which are very convenient to patients. So things are getting better and better.
Right. And you said that this is something that addresses the root cause, which is
That's right. That's
is
right.
weight loss, so to speak.
That's right. It's not just all about diabetes or fat.
Right.
Finally, why do we want to reduce obesity? Reducing obesity is a means to achieving good health. So reducing obesity is the means, good health is the end. So not only do these drugs reduce blood glucose levels, reduce the unhealthy fat in the
Right,
body,
right.
but they also reduce the risk of getting heart attacks, strokes, reduce the fat in the liver, which is commonly called fatty
yeah.
liver. You also get a reduction in what is called obstructive sleep apnea. People getting snoring away to glory because they are obese, getting disturbed because the carbon dioxide accumulates during sleep, and then sleeping during daytime, which is potentially, a threat to as far as mortality is concerned.
Yeah.
So all these different organ diseases are addressed by this one drug.
Wow. So it actually is potentially
Yeah.
a wonder drug if it's
Absolutely.
used correctly.
Correct.
Right? So what is in your definition using it correctly?
So I would say the drug should be used exactly as the label, specifies. Every drug has a label which is given to it by drug regulatory authorities.
Yeah.
If that is followed to the T by a person who is well versed in that medicine,
Right.
and you choose the right type of patient, which could be simply because they've got type 2 diabetes, either as a first line drug, or a person who already has had a heart attack or a stroke, you want to reduce further risk to the heart,
Right.
or a person who has got compromised kidney function in diabetes. These drugs also slow down the rate of kidney decline. But if you're using them for obesity, then there are clear-cut body mass index criteria
Right.
which ought to be used. So, for example, if your body mass index is 30 and above, you may not have any other comorbidity, but you're well within your right to use the drug as per the label.
Okay.
On the other hand, if your body mass index is 27 and above, but you have one other comorbidity, whether it's like obstructive sleep apnea or fatty liver, then you are within your rights to use the drug.
Right,
So the
right.
drug should be used wisely. The patient should be chosen wisely.
And then, as we talked about a little bit earlier, there's so much noise and talk about it as various things that people have to say. People talk about, the side effects are unknown or side effects are very bad. It's not been around for so long. What are your thoughts on the side effects
So
aspect?
the first thing is any drug gets approval only after it has gone through a very rigorous drug development program.
Right.
So if I have to speak only of semaglutide or Ozempic, it has undergone more than 50 trials.
Absolutely.
Which are phase 3 trials, not trials
Phase
in
one,
animals.
yeah.
Okay? They are human trials in patients, and more than 50 such trials in more than 5,000 odd patients have been conducted across the world at different centers.
Right.
And they are subject to scrutiny by drug regulatory authorities. Only after a drug undergoes this trial by fire will it get an approval from US FDA or
Right,
the Union
right.
drug regulations. So one should not worry that it has got premature approval. There's no such thing.
Yeah, exactly.
Now the point is, when the drug is prescribed, you have to counsel the patient how to use the drug. If that counseling is not done properly and the patient starts using the drug inappropriately, they'll end up with adverse effects.
Yeah.
Which is actually not the fault of the drug. It's because maybe they were not counseled well or they did not follow the advice given by the
Right,
doctor.
right. So you're saying a lot of the noise and sort of bad press that it's getting is the misuse of the drug as
Misuse of
opposed
the
to the
drug.
use
Yes.
of the drug.
Yeah. Use the drug wisely. Usually there will be no adverse effects.
Right. Because it's so, easy to get now and so easy to access, and as you said, the benefits are clear and so tangible for people to see.
Correct.
I suppose what happens that they say that, chalo, let me take an extra dose today or something like
No,
that.
no, that should not
which
be
is which is exactly perhaps where
What's
the
happening,
misuse.
Unfortunately, that's what is happening.
Right.
If you strictly go by the book, as far as indications, contraindications,
Right.
adverse events, dose schedules, how to escalate the dose, when to de-escalate, I don't think there should be problems for the vast majority of patients. They'll only
Right.
benefit from the drug.
Right. And then, of course, there is other discussions or let's try and break down some myths also. Like, for example, one of them is that once you start this, you have to be on it for the rest of your life.
See, the point is any drug can only be expected to work so long as you use it. So the drug will work if you're going to use it. If you discontinue the drug, basically what it does as far as weight is concerned, we must understand that. Every body has a weight set point. And that set point doesn't change. It only seems to go up. It never comes down. So suppose your body now has a set point of, let's say, 100 kilograms. Now, it's not going to automatically come down to 80 kilograms.
Yeah.
If you try to starve yourself, your body perceives it as a threat to your survival. And the human body is built for survival across the evolution.
Right.
So our bodies are meant to grow. They are not meant to shrink.
Yeah.
So if your body's set point is 100 kilograms, come what may, if you try to reduce your weight through any means, your body will now adapt itself such that it will promote further weight gain and take you back to that set point of 100 kilograms, which is the common experience. And you try some lifestyle modification, you will lose weight up to a point, you will reach a plateau, and then if you let go of that lifestyle modification, you will go back to where you were. Now, what these drugs do is they shift the body's weight set point. So the body is now fooled into believing that rather than 100 kilograms, your set point is 80 kilograms.
Right. Okay.
Now, so long as you take the drug, the body will be fooled. Now, once you stop the drug, the body will realize, oh, you are fooling me. Our set point is 100 kilograms.
Right, go back
Let's
up.
take you back there.
So that's where the people think that when you get off, you
But
put
that's
the weight.
only to be
weight
expected.
back.
You can't expect a drug to continue working when you have stopped it.
Which is why the other important thing that you said is that you have to get the lifestyle right along with it.
You have to get the lifestyle. This is not a substitute for lifestyle.
Right.
Remember, all the trials with these drugs were on top of lifestyle modification.
Yeah.
It is not that they did away with lifestyle modification.
Yeah.
Every one of these patients who were enrolled in these trials had a 500 kilocalories deficit diet on a daily basis. They were exercising for 150 minutes per week. They were being given, counseling for lifestyle modification. And on top of that, these drugs were used.
Right, exactly.
So you can't substitute lifestyle with this. But people sometimes seem to confuse lifestyle only with diet and exercise. The other important thing is to completely stop smoking or using tobacco in any form. Moderation of alcohol, reducing your stress, having a proper sleep. All these things are equally important components of lifestyle modification.
Absolutely, because I think I've also been, spending a lot of time reading about this lately, just so that we can have this discussion. And a lot of things that I've been reading about is that this can really, this drug can really supercharge your life if you use it as a tool with your lifestyle.
Absolutely.
Not as a substitute.
You can expect about 10 to 15% of weight loss with semaglutide, and even higher with tirzepatide or Mounjaro, even higher, up to 15-20% also.
Right.
These are unprecedented figures, of weight loss.
Yeah.
We could never achieve them with the previous drugs. Because it's simply impossible. So in that sense, these are revolutionary drugs.
Right.
There are so many anti-obesity drugs, historically. All of them fell by the wayside because of adverse effects. Some of them were bad for the heart. Some of them caused suicidal ideations.
Right.
Some of them had valvular problems in the heart. They had to be withdrawn.
Interesting.
Now, these drugs are here to stay.
And you're saying that's because of those adverse effects are not as...
No, they are not as bad, and they're usually transient. They can be easily addressed.
They seem to be more gastro-related.
Yeah, they're more of gastro-related, and usually it's the fullness of the stomach, because I told you gastric emptying is slowed.
Right.
So you will get a feeling of fullness, and the brain also gets a signal that you're full.
Right.
So that's the most common adverse effect, if you want to call it that.
Right.
But some people, confuse fullness with nausea. So if fullness continues, then it's the nausea that starts.
Right.
And if nausea continues, it's the vomiting that comes. And sometimes people get diarrhea, or they can get constipation.
Right.
But if they, follow certain instructions, usually these gastrointestinal adverse effects can be minimized, and they're usually transient.
Okay. And now at least coming to the Indian context, the other, big thing that everyone is talking about is that a lot of these molecules are coming off patent.
Yeah.
So, now it's becoming widely available in terms of A, being cheaper,
Yeah.
more drug companies
Yeah. Yeah.
manufacturing them, and
Yeah.
so forth.
Yes.
Anything that you want to highlight or to think
So
about from that
the
standpoint?
patent of semaglutide, that is Ozempic,
Ozempic.
has expired. Remember, it's the product patent that has expired, not the process patent.
Okay.
So now people are manufacturing semaglutide product or the molecule through a different mechanism, an entirely a chemical process, when previously the original or the innovator molecule is done by recombinant DNA technology. So this is a completely chemical process. It's a bit difficult to replicate the process for oral semaglutide
Okay.
because this was the first time a protein came as a pill. So you have only one company, Indian company, that manufactures an oral semaglutide.
Okay.
Again, through a different mechanism.
Right, right.
Injectable semaglutide, there are more than 50 companies manufacturing it today. Tirzepatide or Mounjaro, the patent still continues. So there is no other, competitor
Available,
or
yeah.
a bioequivalent for tirzepatide. So the advantage is the cost is the same.
Yeah.
And of course, the Indian drug regulatory authorities have given approval for these bioequivalents, as they are called. But remember, they do not have the label for reducing the risk of cardiovascular disease or reducing the risk of kidney disease progression, because such trials have not been conducted
exactly,
in them.
yeah.
They're only conducted with the innovator.
Right,
So
right.
people should be aware of that.
Okay. So, Doc, who should not be taking these drugs?
Well, technically, any drug, you can have a hypersensitivity to the drug. Your body simply is allergic to the drug. Obviously, you cannot take that drug. There's a very rare form of thyroid cancer called medullary carcinoma of the thyroid. So
Right.
if there is a history of that, either in the person or in the family, then these drugs are not given. If there is a history of inflammation of the pancreas, so what is called pancreatitis, in the past, these drugs are simply contraindicated.
I see.
Semaglutide, only 3 days ago, received approval for use above the age of 12 years. Previously, the approval in India was for 18 years and above. Now it is 12 years and above. They are not to be given in pregnant women, in women who are breastfeeding,
Right, right.
and women who are of a reproductive age who are likely to conceive without contraception. So that should not happen. So there are certain contraindications to the use of these drugs. And as far as diabetes is concerned, it's only the common garden variety of the type 2 diabetes where it is indicated. You cannot give it to children with type 1 diabetes
Okay.
or people who have other forms of diabetes, like, during, what we call as pancreas
Interesting. I
stones
see.
causing diabetes. It's only type 2 diabetes,
Right.
which is, of course, the common variety of diabetes where you can use it.
Okay.
Again, very technically speaking, it should not be used in pre-diabetes unless the person is obese enough and merits the drug because of the BMI. But if you have a normal BMI and you're a pre-diabetic, technically you don't have the label for using that drug.
So you shouldn't be taking it for cosmetic reasons per se.
Not, but at least consult an expert before you decide to do it.
Yeah, fair enough. Absolutely. So I mean, this all sounds very interesting, cool, maybe a little bit scary for some people. As we keep hearing, which is true, that diabetes is also increasing, with our population. But with this kind of drugs getting out there, and perhaps hopefully people getting more educated about them and using them the right way, where do you see the future of diabetes going in that sense?
The future is only more exciting because there are better and better drugs in the pipeline. For example, these drugs do nothing to the body metabolism.
Okay.
All they do is to work at the level of the brain, improve the satiety, reduce the hunger, change your food preferences for the better. But they do not increase the rate of metabolism of the body. Now you have drugs which will also, increase the rate of body metabolism. So you will consume calories faster. And there is some, concern about little muscle loss that accompanies the use of these drugs.
Yeah.
Now you have drugs in the pipeline where muscle loss, your muscle will be preserved.
Oh, really?
Yeah. So
Wow.
there will be better and better drugs in the pipeline. I only hope they don't fall by the roadside because of adverse effects.
Yeah.
But in the next 5 or 7 years,
That's
you will have a
fascinating.
revolution in the field of diabetes and obesity.
Yeah, because I was going to say, one of the things that that I came through in my reading is that one of the negatives of this of these GLP drugs is that if you do tend to lose weight, people tend to lose muscle. So that's why the lifestyle comes into aspect of making sure that you're doing your weightlifting or any kind of exercise along with the right amount of protein and so forth. But that's also exciting in terms of what you're saying.
Any weight loss is inevitably accompanied by muscle loss. And may I add, it's inevitably accompanied by hair loss.
Okay.
Okay. But relatively speaking, with the use of these drugs, the fat loss is more compared to the muscle loss.
Of course. Yeah.
So the ratio of fat is to muscle actually improves when you start using these drugs. And there have been studies to do, look at muscle function. For example, hand grip. So actually, after use of these drugs, hand grip improves.
Okay.
So though the muscle mass may in absolute terms reduce,
Right.
the muscle function improves, but relatively speaking, more fat is lost than muscle.
Yeah, body composition is
Body
changing.
composition actually improves,
Yeah.
relatively speaking. Though in absolute terms, you will lose a little muscle, which is why, as you mentioned, resistance exercises are very important to maintain muscle.
Yeah.
Protein intake is important, which is a little bit of a challenge in a predominantly vegetarian country like
Right,
India
yeah.
to increase protein in the diet. But yes, you have to try to increase the protein intake and do muscle resistance training to, maintain your muscle mass.
Right, right. Incredible what we can do in the future.
Yes.
Anything that you think that we haven't covered that you'd like to?
No, I would say we should, change our attitude towards looking at obesity and looking at people with obesity. Very often, people with obesity are shamed.
Yeah.
They are named and shamed, and they are blamed for their obesity.
Yeah.
It is not their own choice. There are so many genetic, socio-cultural, epigenetic factors, as we call them, which play a role in, obesity. So the person is not the culprit, rather the person is the victim.
Yeah, absolutely.
So just like we look at other diseases like diabetes and blood pressure, we don't blame the diabetic person for their diabetes, but all the time we seem to be blaming the obese person for their obesity.
That's a very
so that
good-
should
that's a-
stop. And the discussion on the dinner table should not be the obese person and their obesity
Yeah.
and what they should and should not eat.
Right.
So they should be left to themselves. We should not be judgmental. And it should be approached like any other disease which also can require pharmacotherapy.
Yeah.
So where appropriate, pharmacotherapy should be advised. And there's nothing wrong in taking pharmacotherapy for obesity, because obesity is not just a disease. I will say it's the mother of diseases.
Absolutely.
So if you want to treat diabetes, you first treat obesity.
And
if
that's
you want
again-
to treat blood pressure, first treat obesity. Automatically, those things get treated.
Which is what you started with.
Correct.
With the root cause.
The root cause is obesity.
Is obesity.
If you treat that, then you can treat the other offshoots of obesity as well.
Which is what hopefully these GLP-1
Yes,
drugs
yes.
are
That
starting
is
to
what they
do
do.
and
That's right.
what they
That's
do.
right.
So, and I guess again, used in the right context, it is a wonder drug.
Yes.
Well, lovely, Doc. I think it's very fascinating
Thank
that of all the insights that you've given us and help to break down a lot of the noise that is
I hope so.
is swirling around, both negative and positive. So hopefully, it's given people a little bit better perspective in terms of how they should be approaching it
Hopefully, yes.
and improving their own health. So thank you very much for your time
Thanks a
and,
lot
and
for having me
clarifying
here,
that.
Tawas.
Thank you, Doc.
Thank you.
Thank you all and hope you enjoyed this week's episode. But before you leave, do not forget to hit the like and subscribe button here at the bottom. And any comments you may have, please do leave them as well. See you all next week. Thank you.